Welcome to Docs Talk, episode 39. Today we have Dr. Karin Cesario. She's here to talk with us about alcohol. With the holidays coming, we thought it would be helpful to talk a little bit about alcohol as it's present at every single holiday party I've ever been to, and lots of opportunities for increased alcohol use during this time of year. Dr. Cesario is a hepatologist, that's a liver specialist. She trained at University of Colorado for medical school and residency, then went on to Cleveland Clinic for her gastroenterology fellowship and a transplant hepatology fellowship. We asked Dr. Cesario all sorts of questions about alcohol, risks, are there any benefits to alcohol, alcohol use during and after COVID, which I found particularly interesting, and just lots of questions, lots of information. In fact, we learned so much that we asked Dr. Cesario to come back for another episode to talk about the liver, what it does, and diseases associated with the liver. Also, I wanted to mention that I started a petition. Medicare is ending coverage for home telehealth visits for all Medicare patients as of January 1st, 2025. I just think this is wrong. Patients, especially in the rural areas, rely on these visits for a lifeline, provides access to care, reduces need for travel. And we're trying to increase internet exposure in rural areas, and now Medicare is ending this benefit, allowing telehealth visits. So, started a petition, and hope to please share it. Please consider signing it, share it with your friends and family, and we'll hopefully get Congress to reinstate access for home telehealth visits. As always, please like, share, subscribe. Really enjoy hearing your feedback about our episodes. And as always, if you have a second, please leave a review. It helps our listeners find the podcast in the search algorithms. And without further ado, here's our interview with Dr. Karin Cesario.
It is my pleasure to have Dr. Karin Cesario, a co-worker for many years, in our podcast talking about a very important topic is the alcohol. Alcohol is used in many cultures as a spirit, but sometimes we can overdo it. And so this podcast is sort of to inform us about alcohol and the limitation. One of the questions I had, Karin, is how much is a safe amount of alcohol to drink for both male and female, and what's your thought on that?
The pendulum is definitely changing, and I think right now it's really the answer is there's really no safe limit for alcohol. To be deemed safe, something has to have valid evidence that below a certain level there's no risk of injury or illness. So alcohol would not meet that criteria. Drinking alcohol is related to premature death, increased risk of cancer, of course, liver disease, pancreatitis, certain neurologic conditions, and heart conditions, arrhythmias, cardiomyopathy. In fact, in researching for this podcast, I found a really interesting statistic, which is alcohol is actually classified as group 1 carcinogen by the International Agency for Research on Cancer. And that's in the same category as asbestos, radiation, and tobacco. So the pendulum has swung, and there really is no safe limit. No alcohol is best.
We've heard a lot about, and I think it was in the 80s and the 90s, about this whole French paradox and the red wine. And is there any validity to that? And is there any health benefits, for example, of red wine, or is that just largely marketing?
There were those epidemiologic studies showing that light alcohol consumption may reduce cardiovascular risk. But this is 2024. We have better ways to do that, namely exercise, eating well, and the healthiest option is to avoid alcohol and do those other things to limit your cardiovascular risk.
Is any type of alcohol is different than the other ones?
Well, when you're looking at sort of quantitation of alcohol, you do break it down. So one alcoholic beverage would be 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of spirits. So there's no alcohol that's better for you. It's just the quantity that you're looking at.
And you hear a lot about, moderate alcohol use. Are there some, could you give us some info about what does that really mean? Is that a number of drinks, amount of alcohol? Is there a difference?
So when we say moderate, it's always really interesting talking to patients, right? Because moderate is kind of how you grew up, right? And who you surround yourself with. But I try to put everyone on the level playing field and say that this is a medical definition, and moderate alcohol consumption is considered 1 drink a day for women or 2 drinks a day for men. So heavy would be 2 drinks for women a day and 3 drinks a day for men. And heavy alcohol consumption puts you at risk of those alcohol-related complications. So it's just really interesting talking to patients because they may be in a work environment or grew up in a household where, their parents would split a bottle of wine after work, and they always say, but they've never been drunk. How could they be at risk? But it's 1 for women, 2 for men for moderate, and then of course within those drink parameters that I said.
And when you look at the international, this moderate is so different. I was looking like in Chile, it's like so huge. But I mean, in Japan, it's enormous compared to we think American drink, but some of the other cultures are, and even Canadian. So it's a very, as you said, it's culturally and family dependent. Of course, the nutrition that goes with it is as well is beside the moderate consumption is how much nutrition, because it's so many people use that as a calorie replacement and they do not eat good nutrition, and that's how conjugate more end stage liver or memory loss from lack of vitamins and nutrition.
Absolutely. Patients that are hospitalized for alcoholic related complications, about 80% meet criteria for protein calorie malnutrition. And again, they're just getting so many calories from alcohol and not enough from a well-balanced diet.
No, boss, you had a question. I just wanted to ask you. You said the definitions are different for different cultures. Could you explain that? Because I wasn't aware of that.
Yes. It's per gram of the alcohol, and then when you there's a whole chart goes through the level of the drinking that is sort of common, sort of expected in different countries, and it's like a country like Chile, females they can drink like 3-4 drinks a day, and males like 4 drinks. The same times, for example, if you travel to Japan, there's an area called Hirajuku. Is the biggest density of the alcoholism in the world at night, or alcoholic use in at night is. So it's culturally dependent, and we think United States, but United States is when you look at the whole global use. So it is. If there's a chart, actually, I wish I had it with me. It's very, very interesting that to see what are the acceptance drinks, and each culture's moderation is very, very different than that. So in some cultures, they say you should drink every other day to cleanse your liver and for special occasion. Yeah, it says that the definition is very different from acceptance from one culture to another culture. Not every person that uses alcohol becomes the end stage liver disease. Can you put some thoughts on that? Some people how can prevent from getting to the end stage, whether liver or CNS or cardiomyopathy. What are some of your thoughts on that?
So we certainly do not understand why some people drink excessively and never get any complications of liver disease. But there are also well delineated risk factors, type 2 diabetes, obesity, a pre-existing diagnosis of fatty liver or viral hepatitis. Tobacco use has long been linked to rapid progression of fibrosis from alcohol. And interestingly, a Roux-en-Y gastric bypass increases your risk of alcohol-related liver injury.
Can you explain what that is?
Do you mean the surgery or the risk?
The Roux-en-Y. Our listeners may not be familiar with that.
Sure. So a Roux-en-Y gastric bypass is a bariatric surgery, a weight loss surgery that was really in favor maybe 20 up to 15 years ago and is less in favor now, but it's a rerouting of the intestines. And so you have a shortened amount of small intestine, and so less absorptive capacity. And for unknown reasons, patients with the Roux-en-Y gastric bypass are more sensitive to alcohol-induced liver injury.
Do you think this is because of the alcohol dehydrogenase that is a little less in female and bypasses the stomach to break down the lining is sort of breakdown?
Sure, perhaps. And that is well linked to females having less gastric alcohol dehydrogenase and therefore making them more susceptible to liver injury.
Some of this, Rob, is some of the male through the history, there were more drinkers, of course, from Egyptian to Greeks to there. So they have developed sort of protective enzymes in the stomach called alcohol dehydrogenase. So sometimes for an Irishman can drink 4 drinks, the liver see 1, and the female can drink 1 and liver sees 1. So certain cultures like Native American or female or people with lack of the stomach because of surgery, the liver doesn't know. So when it gets there, the damage is get done. And I think Roux-en-Y could be also the nutrition effect as well. Don't you think so?
Yeah. Sure, I bet.
And let's talk a little bit about acute alcoholic hepatitis, which is a little bit different things. It's more of a binge drinking. Can you elaborate on that? And has very high mortality as well. We see that quite a bit in the hospital setting.
So acute alcoholic hepatitis is a result of excessive drinking and resultant liver failure. And it's a really interesting liver condition, actually, because although 40 to 50% of patients who get acute alcoholic hepatitis have pre-existing cirrhosis, that means almost half do not. And the mortality is incredibly high. We have very, very ineffective treatments. And oftentimes these patients are not candidates for liver transplantation. So it's often Dr. Shafi and I seeing very, very young people dying of acute alcohol-related liver failure.
Is there an amount of, is it more the binge drinking or the total amount or both? Is it, and kind of, could you give us an idea of how much you'd have to drink to get that complication?
Yeah, I'm not sure I know that statistic, but again, it's often following just a 2 or 3 week binge, and then people get very ill, start vomiting, getting jaundiced, and they come in liver failure, and they've been unable to drink or eat, and they're very malnourished at that point.
And one reason, Rob, is they're not candidate for liver transplant. In most centers, they require some good social support and 6 months of the alcohol. That has been challenged in some centers. And so by the time you get them through that sort of sobriety to get them there to psychologically evaluate it is sort of, unfortunately, is a little too late. So and as you said, nutrition is amazing. That's when they go through that. And if they can get good nutrition, maybe there's some hope. Well, some of the things that I always been interested. We have for past 30 years that I've been a gastroenterologist. We have come along with so many good medicine for IBD, IBS, ulcers, but with this we have not made any progress. And even steroid that been used for a long time is controversial from country to country to institute to institute. What's your thought in that? It's just a different disease, I believe.
I mean, there's so many facets to alcohol-related liver injury, whether acute or chronic. I, we have very few treatment options. Yeah, they get admitted to the hospital. They have a high discriminant function score. They get put on steroids after 7 days. If they haven't met certain criteria, the allele score, you take them off steroids and that's it. That's it. That's all we have. And what's interesting is if we talk later about treatment of alcohol use disorders, the disulfirams and the non-FDA approved baclofens, they're all contraindicated with acute liver injury or cirrhosis. So we have very few tools in our toolbox. And again, I don't want to get on a soapbox, but we just don't have enough research in this area.
And it's such a common disease all around the world. And let's go back a little bit to, I was saying some, for past 10, 15 years, in female and African American, and particularly since COVID, the statistic has even continued to rise and not go back. What are your thoughts on that? What do you think? Besides absence.
Yeah, I mean, I think there's so much that needs to be done in terms of alcohol education, but the statistics from COVID are just horrific. I was looking through some Journal of the American Medical Association articles. In March of 2020, there was a huge spike of retail sales of alcohol, not surprisingly, right? We were all sitting at home and the liquor stores were open. But what was really interesting is 60% of people increased their alcohol consumption in 2020 or thereabouts. And like you said, Abbas, it hasn't come down at all. In fact, so there was kind of a gradual rise in alcohol use, this incredibly large spike in 2020, and it just continues to go up. It just never came back down. And then, of course, we're seeing the repercussions of that. In 2022, there was a 25% increase in alcohol-related death compared to 2019. And there's been almost a 200% increase in the number of liver transplants performed for alcohol-related liver disease since 2020. 200%. So it's a mess that we got ourselves into, and it's not going away.
One of the things that I've always fascinated me about the liver is so many of the conditions are clinically silent or just very, very mild symptoms until it gets really severe. As a liver expert, could you discuss about some of the synergies between, for example, fatty liver disease and other liver diseases and how alcohol can impact those? Because we've covered fatty liver disease at length on the podcast, and we've discussed that, diabetes and metabolic syndrome, but alcohol kind of changes that equation a little bit. I understand.
I explained when I'm talking to patients, I said, you don't want to add gasoline to the fire. So if you have any pre-existing liver disease, and the ones, of course, that are most common are viral hepatitis and fatty liver, but really any underlying liver disease, patients should not be drinking. Again, I make the point that none of us should be drinking, but there's other ways to, it's a carcinogen. If you think of it as a carcinogen, none of us should be drinking, but certainly not adding gasoline to the fire in patients with any pre-existing liver disease.
I think that one of the things is because it's such a socially accepted, and for example, in the government and every party you go there, because of them, I think it's just the rule and regulation pushing on that, on the media and all of that. That sort of is I don't see it. It's just hidden agenda, and instead of the confronted in the in what's that in the media, and talk about, if anybody else, you look at those data that would cause any disease would cause that. I think you're going to be in a high agenda, but unfortunately we don't see that hardly any be covered in any news. If it is a small amount that get coverage.
Yeah, I mean, last year in Colorado, there's a really good article in the Denver newspaper about how alcohol has been so laying low under everyone's radar. There are actually more alcohol-related deaths last year than opioid overdoses. And think of how many times we hear about the opioid crisis. And we never hear anything about this alcohol crisis that we've gotten ourselves into since COVID.
Why is that?
I don't know, just because it's been legal for so long. I mean, but even marijuana, I see much more press on the effects of marijuana on the brain. And of course, my boss and I are gastroenterologists as well. So cannabis hyperemesis syndrome and the alcohol just keeps ticking up. I'll need to think about your question. I don't know why that is, but it does need to change.
Maybe the question was a bit rhetorical, but yeah, I understand. It seems, and I think your answer was a good one. It's that socially accepted legal component. Of course, there's age restrictions on it, but anyone who goes to a U.S. College will know that that's really just a suggestion, not a real, yeah.
As a foreigner coming to America, you think you come to the land of intellectual, and when it's college day, you're shocked to see what goes after the football game and all of that. This is, oh my God, these are the people controlling the world. These are the genius of the world. One time I was walking in a campus with actually my chemistry professor, and we were talking. And he says, if an alien come here to think that this is our institute of education, you think what kind of civilization we are. So
yeah.
So it's there. So how can we prevent alcoholism? It's beside the thing is a disease as well. What your thoughts on that?
So I thought about this, and we all need to come together, from the top down. It might be politically charged, but I think starting with just heavier taxes on alcohol, just making it more difficult to get, more expensive to get, may make people think twice. And then, of course, the education that we're talking about, that alcohol killed more Coloradans last year than opioids, but we just keep getting hounded with this opioid crisis, which I don't mean to, criticize in any way. That's an adjuvant problem, but that alcohol also needs to be held to that same standard as in terms of a crisis. I think as doctors we can do better. I think from primary care to subspecialty, you can really get a quick flavor on if your patient's verging on alcohol use disorders just by asking a few simple questions like, how many times last year did you drink 5 drinks or more in one setting? And I don't know what your guys' answer is, but my answer would be 0. 0 last year, 0 the year before that, zero the year before that, but you can quickly kind of hone in on who might be at risk. And there's a lot of data that once someone's getting into an alcohol use disorder, early intervention is helpful. So if we can look to our doctor colleagues to screen more appropriately. And then I think for the individual, easy to say, but never think of alcohol as a carcinogen. That's what it's labeled as. And if you never start, you won't get into trouble. But if you do start, pace yourself, alternate water and alcohol and eating and just slowing it down. And then there's a lot of data also. Don't drink alcohol if you're feeling negative emotions, if you're sad or angry, because you're more likely to drink to excess. Not keeping alcohol in your home. I see a lot of patients that drink because they have anxiety or depression. And I tell them, well, they know this, but alcohol is a depressant. It's not a good treatment for depression. So seeking therapy or help for underlying anxiety, depression early. And then again, if you're falling into that cycle that you're drinking more and people are starting to notice that it's hindering your relationships or your work, then getting help early.
And also lack of the mental health in this country. And sort of that's another thing that's been pushed to the side. I mean, we talk more about it these days, but to get into a patient to rehab or get into a patient to a psychologist in some insurance company, they do not still accept, the method of payment and all of that, or the same thing. So it's sometimes people, I think they feel lonely and stressed, and there is no window out, and alcohol and drugs are in every corner. So I think the lack of mental health, I think, is a big culprit in this as well.
Could you give some thoughts, Karin, about individuals who have a family history of alcohol use disorder, and there's such a strong prevalence in families. Is it genetic? Is it environmental? A component of the two?
I think it's probably, again, this is just, I don't have any data to back this up. Having been a hepatologist for over 20 years, I get the feeling that it's probably both. So I take care of families where that, whether it's an addiction gene or an alcohol gene, I don't know what, but you just see it so deep, aunts and uncles dying of cirrhosis and nephews and nieces dying of liver cancer, and it just goes down the whole pathway. But then you also see these patients that they took a 180-degree turn. They say, my grandfather's an alcoholic, my father died of cirrhosis, and I will never touch a drop of alcohol. I always find that interesting.
Same.
You see that deep-rooted familial line of alcohol use, and then you have those sporadic people that are like not going that way.
And I'm sure you've seen a lot of the patient that I've seen people that come with, GI bleed, varices. And once they stop drinking, give them 6-7 months, the one that really listens. I had patient on transplant list, and they become coaches. They become there, and then they got them off of the transplant list because they were, the alcohol is the poison. Once you stop it, it's not like chronic viral hepatitis or autoimmune disease. You really, the liver will try to heal if you just give it a chance. You just need to stop the poison and give it some nutrition.
I tell patients all the time, it's the easiest cure. You don't have to take pills, you don't have to take medications, you don't have to change your diet drastically. Just need to cut out the alcohol. And it's easy for me to say, right? But you're right. Sometimes I can think of a patient I've taken care of for 20 years who I met in the ICU, on dialysis, on the ventilator, not a transplant candidate, GI bleeding, miraculously survived. And now 20 years later, he's on no medications. No
Wow.
medications, not even a diuretic.
Good
So
for him.
Yeah.
just kind of
I've seen
melts away.
several patients just like that. I remember one of my patients, his son was in University of Kansas, and when he brought it here, it was completely ascites, and unfortunately, he smoked, drink, partied, and stuff like that. And and he made it through the GI bleed. He made it through there. Nutrition improved. He had good family supports, and then this is you're not anymore candidate, and he become coach and and unfortunately even he quit smoking. I think it took about maybe 15 to 20 years later on, he developed lung cancer and come to hunt him. Those, as you said, this carcinogen combination of alcohol and tobacco. So by then it's yeah, it's really once the light goes on, which is very difficult because the temptation, I think is one of the worst addiction, cigarette and alcohol, and there is they're so common, they're so available, and this is the lack of family support and mental health. It's easy to treat yourself and then find yourself in the corner, and then it's tough to get out of it. Yeah. So um, how to treat or prevent alcoholism? We talk about it. And I seen you have a beautiful sheet that you give to the patient, ask question, and actually I read through some of them. Those are sort of questionnaire you ask the patient, and then how do you set the goals and how you treat them?
Well, I am a true believer in counseling. And I tell patients, you have to find what works for you. If some people do well individually, some people do well in a group, faith-based, not faith-based. You really just have to go where you're comfortable. I do believe in finding a sponsor, even if you're in a non-faith-based organization, someone you can call outside your family who's been there, who you can go to if you have any temptations. Um, I touched on earlier, I don't we don't have a whole lot of pharmacologic options right now that are especially for our patients that already have liver disease, but more research needs to be done in that area. Of course, anti-abuse, and there's all sorts of interesting things coming in the pipeline, but nothing that works as well as therapy, I think.
Do you ever use those medications like anti-abuse or any of those other like is it now naltrexone? There's several of
Yes,
them that are used for this.
yes. So they are. I alluded to this earlier. They're contraindicated in patients with liver disease. Uh, so it's a conundrum you get in as a liver doctor that you can't treat your own patients. But I wouldn't feel comfortable using any of these medications anyway. I work closely with several of the rehab organizations in town, and they will try things every so often.
And most of the rehab have to be self-motivated to go. Is that correct? To be successful. And I seen in my patient, the patient, if they're pushed by the law or family, the chance of that I see so much. But when they're motivated, the light goes on and they volunteer. I think that's the most success, at least in my practice. And I see a lot less, I mean, these days compared to you. So what's your thought in that?
Absolutely. In fact, I call myself, baby doctor 25 years ago. I used to, get all the info, and we'd call together, the patient I would call in the exam room and set up an appointment, and then they no show, 80% of the time. So I 100% now put it on the patient. I said, I'm not going to do this. I will give you the number, but I'm not going to call. Your sister's not going to call. Your mother's not going to call. You need to call. You need to work this into your schedule or it's not going to work. And you have to want it. You have to want to call.
Are some of the programs inpatient or are they mostly outpatient?
It depends. There's every option. And I do go through those options with patients. And it depends a little bit also on if they're self-medicating. So you might do better one-on-one if you have underlying anxiety or depression that needs treatment separately, and then also some education on alcohol or substances. But if you truly have that, genetic or cultural, or you just grew up around alcohol and you need to relearn that, sometimes being in a group environment is better.
And some of the patients have addictive personality, and unfortunately, see cigarettes, alcohol, marijuana, then they complain of pain, they end up on, opiates and stuff like that. And when I keep telling them that if once they realize this is a personality and seeking the health, then they may be able to stop some of this, this avalanche going down until destroy them. So yeah, it's not only says limited to United States. It's worldwide problem. Just some more than others. Some so it's a very unfortunately, and we're coming to the peak season of it. Between Thanksgiving and New Year's is that's where you see it the most.
Any advice for folks who are trying to limit or avoid alcohol? Or we have all these toasts and parties, and oh, here's some eggnog and all the other litany of things. Any thoughts about how to manage that situation?
Yeah, I mean, just to be aware that we live in an alcohol culture and to think every time you drink, right? Why am I drinking this? Is it because of toast and it's celebratory and it's part of our culture to celebrate in this capacity? Or am I trying to, am I feeling social anxiety? So I'm trying to get tipsy so I can talk to people. And in that situation, again, just pacing yourself, eating, alternating some water, and just limiting yourself.
And keep yourself interested in other activities, sports. For me, Monday through Friday, chamomile tea and herbal tea is because you have to do something in the evening to drink hydration, and I don't know, on the weekend maybe want to drink occasionally. Yeah, I think just you have to limit yourself and put the boundaries. Otherwise, it's so close by, and everywhere you go, dinners. That's sort of. I was on vacation last week, and people start with samosas in the morning. By 10 o'clock, there's another drink, and after a couple of days, it says, "Oh my Lord."
My liver hurts.
Beside the liver, your mind goes there too. And I one of the things I tell people, it says, if the liver doesn't get you, is the memory care. So those are the two options. Today, I mean, we have cardiomyopathy as well. Nutrition has become a long way, a little better with some vitamin supplement. But yes,
Karin, do you have any closing thoughts, or and how can our listeners find you if they have questions? Do you have any social media or other resources to direct them?
I don't at this time. Still just finding my feet in a new practice. I'm with Peak Gastroenterology on InterQuest, and I work at Memorial North and Memorial Central and outpatient. And I've started doing some outreach work for Anschutz for their hepatology clinic and seeing some of their Southern Colorado pre-transplant patients, post-transplant patients. So yeah, I'm around, but not very active on social media.
So is there any rehab or any centers that you think they're you recommend for your, and probably you don't have the list of them, but do you recommend somebody to seek? I know they're family-based, the faith and all of that, but any centers that you recommend to if somebody wants to seek some help?
So I do have a list, but I don't want to put that out there because again, I really think you have to cater. I try to get a feel for the patient. And if they have underlying psychiatric issues, that may be a different referral than somebody who has polysubstance abuse, right? A boss, somebody who's not just doing alcohol, but smoking and marijuana. And so we do have some good resources in this town. It has gotten a lot better. There's obviously a very big shortage still, but since I came to town almost 20 years ago, it used to be just a couple individual counselors, so
Right.
and
Yes,
AA. So
right, yeah. Well, thank you very much. I learned a lot. Enjoyed talking to you, and I'm sure our audience will enjoy this talk and learn a lot. So thank you very much.
thank you both.